Hello, everyone. Thank you so much for joining us today. Um, Give me 1 second here. I've got some technical difficulties on my end. All right. Today I'm uh, Today I'm joined by Heidi Lucas. She's the director of rural health care at Missouri, and we're going to talk about the $50 billion healthcare fund for rural health and how that impacts hospitals and rural health care in places like Missouri. And Heidi, welcome to the show.
Hi, thank you for having me.
Thank you so much for joining me. Let's just jump right into it. So we're talking today about how the $50 billion healthcare fund affects rural health. If that actually does anything, if it falls short, if it delivers too much, um, what effects does this fund have on current and future healthcare policy?
Yeah, that is a great question. So, when the One Big Beautiful Bill Act that was enacted into law on July 4th, 2025, created that $50 billion fund called the Rural Health Transformation Program, it was an attempt to offset the losses that rural health providers will experience associated with other health provisions that were in that legislation. So that $50 billion will be distributed to all states between fiscal year 2026 and 2030. So about 10 billion will be distributed each year. Half of that $50 billion will be allocated equally among all the states with an application approved by CMS. And the other 50% of the funds will be distributed to states with an approved application and the amount determined by the CMS administrator. And so, Missouri, we are expecting somewhere between 150 to $200 million annually. And in any other time, in any other environment, we would be celebrating. This is a massive win for rural healthcare. This kind of money is what we've been dreaming of for decades to help amplify and bring in money into our rural healthcare system. Unfortunately, it is under the cloud of the Medicaid cuts that also passed as part of this One Big Beautiful Bill. And so, kind of the analogy I've been using, it's really a band aid when what we need is open heart surgery. And so this will be, yes, it's an injection into the system. Yes, we are working on an amazing plan here in Missouri, and I'm sure other states are as well to use the funds. But unfortunately, what good is this money whenever we're trying to recruit, retain clinicians? We could possibly put in new and emerging technologies into these hospitals and FQHCs and rural health clinics. But what good is that going to do in 3 years when they're all closing because of the massive cuts to Medicaid? And so, yes, we are grateful and thankful for this money, but we are very concerned about the future and what that's going to look like if all of these Medicaid cuts go into effect as they were enacted.
Hmm. So from what you said, it sounds like it still falls short of uh, what's going to be needed to counteract the shortfall from the cuts to Medicaid.
Yeah, 100%. I heard this or read this great quote a couple of months ago after all of this was going on. And what the quote basically said was, there is a light at the end of the tunnel. Unfortunately, it is a train coming to run us all over. And I think that is a very apropos thought whenever you're talking about all of the cuts that we're going to be looking at with Medicaid.
Light at the end of the tunnel. Unfortunately, it's a train that will run us all over. So,
Yeah, that's it's, I mean, when you're talking about funding in the billions of dollars a year for each state, I know Missouri is expected to face about a 21.1 billion reduction in federal funding over the next 10 years as a result of that. So, when you're talking about 21 billion reduction, about 12% cut in Medicaid spending in Missouri, and then we're talking about offsetting it with the Rural Health Transformation Fund, which can't be used to help pay for the things that they lost through Medicaid. It really is just a Band-Aid.
so if it can't be used towards things that can actually uh, counteract that shortfall, what can it be used for?
So they were really, really specific in what it can be used for. So things that are allowable expenses are promoting evidence-based interventions to improve prevention and chronic disease management, payments to providers, technology-driven solutions for prevention and management, training and technical assistance for developing and adopting technology-enabled solutions that improve care delivery in rural hospitals, recruiting and retaining clinical staff in rural areas with a 5-year obligation to stay, software, hardware, or significant tech advances to improve efficiency, cybersecurity, patient outcomes, assisting rural communities to right-size healthcare delivery by identified and meeting services, facilities, supporting access to OUD or SUD treatments, projects that support value-based care, and then there are additional uses designated to promote sustainable access to high-quality rural healthcare services as determined by CMS. So here in Missouri, what we're doing, the basis of the project and the application, is we have a program here called Torch. And what the Torch model does, it basically is a hub model where currently in our region is the hub, and then there are lots of different groups that they can work with as part of that continuum of care. So we're talking about social service agencies, other providers, so FQHCs, rural health clinics in their area, things like behavioral health services that they would work with, community paramedics, pharmacists. So the hospital is at the center, and then it works with all of these different groups, and they set a system to work with all of those groups in that area to help improve outcomes in their rural communities. This started out a number of years ago as a pilot with 5 hospitals. It was specifically, this program was called out in the NOFO from the federal government for this project as an example of the types of projects that they're looking for. So Missouri has kind of run with that. And currently the goal then is to kind of expand this pilot program to cover the entire state and start up these community hubs. And then ideally, from the conversations I've heard, is that then that hub in each community, that group would then decide what they're going to use their specific portion for. So is it money for more social service type work, or is it to help support community health workers, or what is it that community specifically needs to raise their outcomes? So they're hoping to have a little bit of flexibility in that. And, I think this is a fantastic idea. I'm very curious to see how it will end up working out when we're talking statewide. Also, the hubs don't necessarily have to be hospitals in the new vision of this. They could be FQHCs or rural health clinics. In some of our areas around the state are federally qualified health centers. They are the only provider. There is no hospital in their region, so they would be the natural fit to be the hub in some of those areas. So all of that is being considered as part of the Missouri model as part of it. of what we're going to do, at least here. And then each state will have that flexibility to be able to decide for themselves how they want to use that funding, as long as it's within those prescribed guidelines that the federal government has laid out.
So you mentioned that the money that's going to be coming in is about 200 to 250 million a year, right? And it seems like the shortfall though is about 2.1 or so billion per year. So if my math serves me correctly, that's still like 1.9-ish billion a year that is still essentially missing, or there's a shortfall of that. So will the other money even matter? I mean, will hospitals be able to survive long enough for that money to even for that the healthcare fund money to actually make a dent in that shortfall for them?
That is a great question, whether or not the hospital are going to be able to survive long enough. So what's interesting is how all of this is being rolled out. So, this money through the Rural Health Transformation, it will be starting next year, beginning of next year. They're hoping to have all of that allocated. The applications are actually due tomorrow. Then the government, despite it being in the shutdown, I've heard that they have brought people back in from the shutdown to start the review process of these. And they are saying that they're still holding to the December 31st deadline to be able to announce who's getting it. So this money is coming in kind of right away. So this extra funds are going to be coming in well before the Medicaid cuts are scheduled to take place. So, we'll have a good year or two before we start seeing some of the cuts to Medicaid. There are other things that are being cut that were in the One Big Beautiful Bill. One of the ones that has a big impact here in Missouri, and I'm sure a lot of other states, is around provider taxes. So provider taxes are what is paying for the Medicaid, like the state's portion of Medicaid. A good portion of that is paid out of provider taxes. And in the One Big Beautiful Bill, there is a cap on that. They have put in that the caps to provider taxes will be at 3.5% by 2031. So, we're looking at these cuts kind of long term. It's going to be incremental that they'll be happening with kind of the full cuts by 2031. So well past this election and well past the next presidential election too, is when a lot of the majority of these cuts are going to take place. So, for example, with these provider cuts, so if it's at 3.5, Missouri's current rate of provider tax is 4.2. Historically, it has been about 5.47 over the last decade of the provider tax. And that fluctuates year to year. And I think they were trying to raise it up again. And so how they're doing it is it will be an incremental phase over the next couple of years to get back down to that 3.5%. And again, with Missouri being higher, it'll take a couple of years before we have to wind that down before the biggest of those cuts will happen. But this is another cut on top of all of the cuts that are being prescribed at the federal level. This is a portion of that kind of feeds that will have dramatic consequences. And, state like Missouri, we're already facing a budget shortfall. And we are kind of a special little snowflake here in the state. We are one of 3 states who passed Medicaid expansion by ballot initiative. And because it was passed by ballot initiative here in Missouri, Medicaid expansion is in our state's constitution. So what that means, the state then is obligated to pay for that Medicaid expansion group while that continues to be in the state constitution. So other states that have passed this the traditional way through the legislative process, they pass their Medicaid expansion, right? And so the prescribed cuts that came out of the one big beautiful bill, they'll be able to go back to their legislature and say, hey, we can't afford to pay for this expansion group anymore. So the 100 to 138% of poverty level, we can't afford to pay that anymore. We can pass legislation in order to strip it, and then we're only then required to pay up to that 100% of poverty level. And so a lot of states are moving into that direction. If nothing changes, I think we'll see a lot of states do that. So Missouri, on the other hand, won't be able to do that. It would have to go back to the vote of the people and have a very large campaign and spend a ton of money, millions and millions of dollars, to try to move the Missouri voters into changing our state constitution and removing those provisions for the Medicaid expansion population. So that's going to take years. So, it would either have to pass through ballot initiative. The legislature could put it back on the ballot, which is how I'm expecting it to go in the future if all of these cuts happen. If, like they're being said, to happen if nothing else changes. And that's going to be a monumental task. But until that point, until that happens, we'll be forced to continue to pay for that. So when you couple that with the provider taxes that are being cut, we're already facing a huge budget shortfall. The budget next year for the state of Missouri, we're expected to have to make about $1 billion in cuts in order to meet the revenue that's coming in. We had been kind of buoyed during the COVID pandemic, the extra money that was coming in, that money has dried up. And so Missouri is going to be between a rock and a hard place in this, is how do you continue to fund that we're legally obligated to fund because it's in our constitution, Medicaid, when we're doing all of these other cuts, the money from the federal government is being cut. So it's going to mean the difference between, fully funding our schools, road projects, federal or state government. There might have to be layoffs at the state government in order to cover for these shortfalls. So we are really in a challenging place that's a little bit different than a lot of other states when it comes to a lot of these cuts. And so, all of that kind of adds up to a perfect storm of terrible that we're going to be looking at, that will force hospitals, potentially FQHCs and rural health clinics as well, to close their doors because of all of the things that are going to be happening. I'm very doom and gloom whenever I come and talk about this stuff anymore. It's we want Heidi to come and talk. Well, it's going to be a little sad. Sorry. I don't have much good news, unfortunately.
Well, I guess if this was a make you feel good podcast, then that would be an issue. I guess for truth isn't always happy or right or but we have a question from the audience from Marty Nichols, and he's asking, there's so much unnecessary complexity added. When we talk about cuts, are they actual cuts in what we're spending today or cuts to the projected budget?
So that is a good question. Yes, so it would be cuts in what we are currently spending today, as well as cuts in the future. So we will not be able to spend as a state as much on these programs in the future. Except, unfortunately, except like I mentioned, Missouri is a little bit different because we are obligated to continue to fund these programs at where they're at currently. Because of that. But other states, there will be a reduction in payment. Many states will roll back their Medicaid expansion if all of this continues to go into effect. And again, a lot of the worst cuts will happen in 2027, 2028, 2029, so well into the future after the next election cycle. And so, we've got some kind of time to figure it out. But yeah, the spending cuts are both, in future projections of the budget, as well as kind of where we're at now, we're going to see some reductions.
So it's a little bit of both, essentially. And Marty is also there was another comment asking, we're talking about HR 2191. That could be a big value to rural health, but isn't talked about often. Is that something that is uh, that we can talk about here, or is that kind of
HR 2191. I don't know that bill number off the top of my head. I apologize.
okay? No, no, no worries. Yes, okay. So we can come back to it later on if anything. Um, okay, so there's a lot to digest here. I mean, because as you've talked about, there's a lot of moving pieces. Not many of them are moving in the positive direction. So it just sounds like whatever barriers there were to delivering consistent, high quality care there was in rural areas, it seems like those barriers are only getting bigger.
Yeah, so there are a lot of barriers to healthcare access in our rural communities. So everything from the number one that I hear over and over again is around transportation services and the lack of options. So say you are working at a job that doesn't offer much sick time or vacation time. And it's hard for you to get off during the week to maybe go to your appointments. So, you have to look at the time it takes that you'll be out of work, potentially without any, if you're working a couple part time jobs, you might not have time off available to you. And then the transportation costs as well on top of that. So the cost of gas keeps going up, the price of cars keeps going up as well. So if something happens to your car and you need a new one, there could be a delay in getting a new one. You might not have enough money to put a tank of gas in your car to travel that distance it is to your provider. And in some of our rural communities, I mean, you could travel an hour or more to see a provider. If you're going to see a specialist and you live in a portion of the state that is far removed from one of our urban centers, it could be 3-4 hours away for you to get to an area to see a cardiologist or a hematologist. So, in order to do that, that's a full day off of work that you would have to take in order to do that, on top of any transportation challenges. So we know that the folks who live in our rural communities are older and poorer and sicker because of a variety of reasons. But one of them is the lack of providers that we have. Missouri is expecting we're about 2,000 physicians short in order to meet the needs. That's a 2026 number. We're 2,000 physicians short. And so that means longer travel times, longer wait times in order to even get an appointment. You could, when you're starting with a new physician, it could be months before you're able to be seen. And so people delay more care in order to, kind of make the time or find time to be able to go. Another issue is broadband access. So there was a lot of money being kind of thrown into the system to improve broadband in our rural communities over the last couple of years. Many of those programs have been cut under the current administration. So lifelines like telehealth are going to become harder and harder. We just passed a audio only telehealth provision that would require private insurance to cover audio only telehealth. That has been a huge help. But, for other things, you can't just do it over the phone. If you need to see the rash on somebody's arm or look into their throat, you need kind of that broadband connection in order to do so. And in many of our rural communities, that's just not likely. They don't have that access available to them for those broadband connections to be able to do that. Also, with technology, we have a very aging population in our rural communities. And as somebody who has tried to show my mom how to use FaceTime, and she's in her 70s, it was a long process. Hopefully, she's not listening today to hear me talk about the difficulties sometimes of trying to get technology and how it actually works to aging parents, the challenges that kind of come with that. whenever you're trying to get somebody to use a technology, which is really, a lifeline to have telehealth, to be able to do those quick one-off appointments, to get the cream for the rash or the antibiotics for your throat. And so that's another barrier. We also have restrictive practice for our APRNs here in the state. So, some states have full practice authority for their APRNs or their PAs, and we don't have that here in Missouri. So that creates some extra layers of barriers as well to having enough providers to provide care in our rural communities. So there are a number of factors that really hurt our rural areas when we're talking about access to care and why outcomes are so bad in our rural areas as well.
So things everything from broadband access to not enough physicians to transportation. Are there those factors are all there to essentially or as potential blockers that keep people from getting the care they need?
Yeah, so all of those things are just, huge barriers that people have to overcome. Even just finding a babysitter, right? If you have to take a whole day off of work, what childcare options are there, especially if the travel is going to take you past 5 o'clock, when you would traditionally have to pick up kids from a traditional childcare provider. Having to balance all of that, it's just one problem after another that folks in our rural communities have to overcome, that they don't necessarily have the same issues in our more urban areas. And the rates of folks who are covered by Medicaid, in rural Missouri, about 26% of rural Missourians are covered by Medicaid. This is versus about 18 to 19% of those living in urban areas. So, you have a far more number of folks that are going to be impacted by these cuts that are coming down. And it's not just the cuts that we're worried about, but also some of the requirements in order to continue with Medicaid. So those are things like the work requirements, the reauthorization every 6 months as opposed to yearly for that expansion population. We in Missouri have a hard enough time meeting our redeterminations in a timely manner. So even though they're done once a year, things get lost in the mail. We don't have enough staff in order to process them effectively. And we have actually gotten into a bit of trouble at the federal level because we have been so slow on going through the redetermination process. They're also, as part of this bill, cutting the amount of time that you can look back. So if it's somebody who is new to Medicaid, right now it's several months that they can look back and say, okay, so, Medicaid can back pay, I think it's 3 months currently, and now it'll be dropped down to 1 month. So if you're talking about somebody who goes into the hospital because a cancer diagnosis, has to quit their job so that they can focus full time on their health care, they would traditionally be covered by Medicaid on that. But because the wait times are very long in order to get approved, it could potentially take that entire 3 months in order to do it, and then Medicaid will step in and back pay. Well, if it's only going to back pay for a month instead, you've been receiving care for the last 3 or 4 months. So now what? How do you pay that bill? You don't. Is going to be probably the answer a lot of the times. Is they're going to have to make that choice whether to pay it or not, and then the hospitals just won't get reimbursed for that. So we're looking at a number of barriers that have been laid out that will also drop the Medicaid enrollment numbers that we're seeing. So folks who could potentially qualify might get lost in that shuffle, whether they miss a letter in the mail for their redetermination, they won't be able to do it. Whether they, something happens within those in that time for that first time that they're going to get it and they're not being covered. And so what is it that they're going to do? So it's not just the patients that'll hurt, it's also the hospitals, it's also the FQHCs and the other providers that are going to be hurt by that, which will lead to closures, and then we'll have folks who won't have anywhere to go and will have to drive further distances when their facilities close in their region.
Oh. So, in your opinion, would if physicians were allowed to own hospitals again, would that help um, any of these issues?
If physicians were able to say that one more time, I'm sorry.
So, yeah, if the moratorium on physicians owning hospitals was lifted, would that potentially help any of these issues?
That's a good question. I don't know if that would help or not. We have a number, not hospitals, but physician led health groups in the state. But if they were able to own the hospitals, you'd probably still have the same issues that we're talking about, right? With the Medicaid not covering people, or the issues that we're going to see with uncompensated care. I don't necessarily think it will make a difference one way or the other when you're looking at cuts like that, or issues that are going to come down around that.
And then I wanted to address one more question from the audience as well. Would the 50 billion be better spent expanding our resident programs to bring physicians into the market?
So that is one of the things that is allowed as part of it. It's into, you are able to do it to payments to providers, as well as doing recruiting and retaining clinical staff. That is one of the things that can be used. And I know states are going to be using it for that. Here in Missouri, we have a robust graduate medical education program that I believe they're going to be asking for more funds as part of this as well, to increase residency slots in our rural areas, because that's a huge problem, is we don't necessarily have enough residency slots in order to cover the need. So I know that is part of the puzzle, but it's just one piece of kind of a 1,000-piece puzzle that we're trying to put together. It is definitely an important one, because we definitely need more providers to stay and work in our rural areas. We have in Missouri, we have a lot of medical schools. We put out, I believe don't quote me on this one, I believe we're the 5th largest producer of physicians in the entire country. So we're putting out a lot of physicians, but a lot of them are leaving because we don't have enough residency slots to go around here in the state. And so that is a big priority for Missouri, is increasing those residency slots in order to keep more staff engaged and working in our rural areas. So that is something that is allowable as part of the expenses. And don't quote me on that 5. Number 5. I'm not exactly. That's the number that's moving around in my brain right now. But we do produce a huge number of physicians that just simply aren't staying in the state.
And because essentially they have no choice initially, because they have to go somewhere else for residency, and then they end up just not coming back.
Right, they end up staying. Because we do see that, right? If you do a residency in a rural area, you are more likely to stay in that. Also, programs that are kind of grow your own programs as well, where we're taking students from our rural communities and putting them into medical school programs with specific rural tracks. The University of Missouri has a wonderful program. The University of Kansas City also has an amazing program that they're just rolling out around rural providers, kind of grow your own programs that really nurture our students, who a lot of them are coming from their first gen college students, right? We have a lot of folks. I was a first gen college student as well. So there's a lot of folks that do that, and they just need a little bit more support. So having programs like that will really nurture and mentor our students who want to be our future doctors in our rural areas, having them get that training and that support in order to move them through, send them to medical school, and then put them in a position to have residencies back in either their local communities or other rural areas because they grew up in that kind of community. They're more likely to say. We see it with nurses. Nurses are more likely to return to their home communities and practice in those areas. And so it would be physicians we're looking to do the same thing.
And is there much traction behind this currently, or?
Yeah, so the University of Missouri's program's been around for a very long time. It has some wonderful outcomes there. And then again, Kansas City University, and their program is brand new. Theirs is a little bit different program and how it's set up than the University of Missouri's, but that's also showing a lot of promise in order to keep the University or Kansas City University's program also does dentists, which is also a huge need in our rural areas. So it is both it is a DO program and a dental program. They have both of those tracks there that are bringing students up from kind of the 4-state area in order to train them, send them to school, and then send them back out to their local area. So wonderful programs that we're seeing and really innovative, and they're showing some promising results. But again, we need more residency slots for them to be able to go into in the future. There's some really great programs with FQHCs as well that can be residency sites, and they offer kind of a different perspective than if they were to do one at a hospital, and so supporting those programs as well.
So I'm going to ask you a really silly question. So in business, entrepreneurs and business people are taught, you have to find your niche and essentially find a way to differentiate yourself in that niche that will cause clients to come to you. Is that possible at all in the healthcare world, where, granted, in rural areas they're limited? Is it at all possible, or I should say, maybe, is it impossible to expand, their reach for a specific niche of clients or patients, if you will, that can to help strengthen their financial positions?
Yeah, that's a good question. So we see a lot of physicians who work in rural areas. You don't get as many of the specialties in those communities just because the need isn't as great, right? But what you do see is folks who kind of like being a jack of all trades a little bit. Like, you have to have a wide berth of knowledge whenever you're working in rural areas, because you might see some unusual cases that'll come through and you might not have access to a hematologist or a specific specialist might not be available to you immediately like you would if you were within a larger system in, say, St. Louis or Kansas City, where you can just kind of call over to the next building and get some expert knowledge right there. When you're working in rural communities, it's a lot more quick and dirty, right? It's a lot more of having to figure it out yourself, having that mentality of, kind of that go-getter and being really curious about trying to come up with solutions. I know somebody who she ended up getting diagnosed with a very rare disease. And she had first gone to her rural hospital in order to receive care. And they didn't just dismiss her claims outright. They really, like, in the emergency room, started to dig in really quickly and start ordering some certain tests to come up with this. Again, it's a very rare diagnosis, but her rural hospital figured it out and were able to offer her, high quality care. But that was because they were invested in her. They were very curious and able to to go in and kind of dig deep without the assistance of kind of some of those specialists. And then once they kind of figured it out, then they sent her out for further care. But they were able to make that diagnosis in-house, because they were kind of scrappy about it, right? Like they were really curious about figuring out what the issue that she was having was, and asking the right questions and doing the right tests in order to get that answer. So, the rural communities, they're just kind of a different animal, right? You're not necessarily in an urban area going to see somebody who may have gotten their foot caught in the combine, right? And what that kind of injury looks like. So you're going to have just different situations that you're going to run into at in the rural communities as opposed to what you see in some of the urban areas.
So it sounds like it depends, right? Essentially, where
Yeah.
depending on kind of on the community and what their sources, um, what the services that they could offer, um, might get enough patients to actually make it worthwhile. And um, okay, so what do you see as potentially turning all of this around? Like, are there any actual lights at the end of the tunnel where something could happen where, the shortfall that we're going to be seeing in a couple of years will disappear?
Yeah. So I think we are not at a point of no return, right? So we do have an election next year. Elections have consequences. Something that I preach all the time is, what happens in elections has long-lasting impacts. But we are at a point where, and because a lot of the changes in the One Big Beautiful Bill are on kind of that longer timeline, you know, there is the opportunity for change. Here in Missouri, Senator Josh Hawley, who is a Republican, so he's part of the majority party in this country currently, he has come out very strongly against a lot of these cuts and a lot of these changes, and has talked about some potential options for mitigating the harm. And so, there is chances in the future to make changes before a lot of these cuts are fully realized. So advocacy continues. We have to continue to advocate for our patients, our communities, the people around us, the people in our state, to get the highest quality healthcare that they possibly can. And what that means is trying to mitigate the harm or removing a lot of these harmful cuts that are coming down the pipeline for Medicaid. And so, we do have hope that there is change that can happen, especially once those cuts starting to happen and we start seeing rural hospitals close. I think that's going to be a catalyst to see kind of the broader changes. So, and again, the hospitals aren't going to close overnight. We're not going to see, beginning of 2026, we're not going to see suddenly 10 hospitals close in northern Missouri, but over the course of the next 5 to 10 years, that could happen. And we'll see kind of an uptick, and it will start moving a little bit faster. And I think that will be a catalyst to change and kind of roll back some of these provisions. Hopefully we can do it before we start closing hospitals. I'm a little bit of a pessimist whenever it comes to that. I think it's going to take something like that. We're going to have to see that starting to happen before real change happens. But I am hopeful that we will be able to really step in. Cooler heads will prevail, and we'll be able to kind of stop some of these things from happening and save our rural hospitals and our rural health clinics and our rural FQHCs in the state.
So, because of the drawn out nature of when these cuts will take place, it's still possible to reverse them depending on what future policymakers, current and future policymakers, could essentially decide.
Exactly. And I mean, there is no dispute whatsoever that the American healthcare system is broken. I think you talk to anybody, and from, an individual on the street, your neighbor, to hospital CEOs, physicians and nurses, you talk to anybody and they'll tell you that the American healthcare system is broken. I think that could potentially be the best outcome that we would see, is that, even if it's being broken further right now, we have the opportunity to build back better and to come back stronger, fix some of the problems. And I'm hopeful, it might be a little Pollyanna of me to think this, but I am hopeful that maybe with all the attention happening right now in the healthcare space, particularly in the rural healthcare space, it will lead us to better outcomes in the future, some innovative thinking. Hopefully with this Rural Health Transformation Fund, we'll see in some states some really innovative models that might have long-lasting implications for everybody. And if we find stuff that starts working and implementing that, we could see better outcomes in the future because of this dark period that we're currently rolling into.
So you're saying it might take a bit of the damage to show to kind of wake people up and show that's a real problem until to force change the other way, where to keep things from getting worse and then maybe even moving it to on the scale to where it gets better.
Yeah, that's the hope, is that, through all of this, maybe that light at the end of the tunnel isn't the train. Maybe it is an actual light at the end of the tunnel, and that will come through this better off and with a better healthcare system than what we currently have, because what we have now is not working. And all of these cuts are just going to make it worse. So I think there is an opportunity to turn the ship around before it is too late.
In your opinion, do you see that there are there any other things like um, do you envision any of the changes coming in from like the entrepreneurial side or from sources that you wouldn't otherwise have expected?
At least here in Missouri, we're seeing a lot of folks working together, that haven't traditionally done so, or have been in a place where there was competition, and because of this and because of the money coming in, they're being forced to work more closely together, and that's really sparking innovation. And I think that's fantastic, right? Like, things around like data systems and the sharing of data to again, innovative solutions, how we can better work together with the kind of continuum of care providers, the homeless shelters, the food banks, how they really fit in to the larger healthcare scheme, and we can bring them in closer with it and really think kind of whole person, holistic care. I think all of that is good. And, because of cuts, and again, this new money coming into the system, they're being forced to think through things as they've not traditionally done in the past. So, I am hopeful that some of that will spark innovation, will spark changes, and really kind of, in the end, have better outcomes for the patients.
So if there's more collaborative thinking and uh, really focusing on the continuum of care um, with different types of entities, that could help turn the tide as well.
Yeah, I really think so, that, the more people can work together, the more organizations can work together, I think the better off we'll all be. And though, it's kind of being forced at the moment, it'll be forced more in the future if we see facilities start to close. Um, but I do think that there is a lot of potential there to um, to make those changes.
Well, Heidi, thank you so much for being on We're All Patients podcast. It's been a pleasure having you here. Uh, we've discussed a lot of details about the big beautiful bill's effects on rural healthcare and especially the $50 billion healthcare fund, rural healthcare fund. Um, yeah, thank you everyone for tuning in, and Heidi, thanks again.
Thank you so much.